Thank you so much for having me. It's so much fun to get to think about this and share with you all. I will say what I'm actually going to do today, Bert, is try to take you all through a journey, a little bit of what happened to us on the forefront of trying to manage the pandemic and how I think clinical epidemiology grew in many ways into its own during that time. And I hope how we can use this time to, in many ways, rethink how we bridge between clinical medicine and epidemiology again and bring that forward. So these are actually, I will say, just musings of mine. I'm not sure that it's ever good to give a talk that is mostly musings, but that is what I'm going to do. And I will say, Bert, my hope was that by doing this, I would be able to get a lot of input from the people who I see as really the world's leaders in thinking about how we do population-based research and epidemiology. So it is an unabashed plea for input is why I'm doing this. I'm really interested in having a dialogue about this. So I'm going to start sharing my screen. As you guys all know, that always takes a little bit of drama. So give me 2 seconds here as I do that. Great. We're going to use multiple screens here to try to make this work well. So let's try this. And how does that work on, whoops, on your guys' side? Can somebody, does that
Yes.
work?
Yes, thank you. Excellent.
Wonderful. So what I want to talk about today is really this concept of what I've learned from being on the front lines of the COVID-19 pandemic over the last year in terms of how we might bridge clinical medicine and epidemiology moving forward. I'm going to really frame it in 3 ways or in 3 sections. And I'd love dialogue. I know it's so hard over Zoom, but I'm happy to monitor the chat or whatever works best for you all in terms of how we have a dialogue here. But so I want to talk about one very, very simplistic perspective on the history of clinical epidemiology. I'm not going to give a lot of references. I recognize I'm like going to the source of the truth as I do this, but I'm just going to give you one perspective. I'm going to share some of our experiences from COVID-19 in terms of how we bridge the need to bring research and bring data and evidence to this incredible clinical need. And I just want to talk about some of what we're working on in terms of future opportunities and then some of the challenges. So I don't think I have to share with all of you, but I've been reading a lot, again, about kind of the history of clinical epidemiology and the birth of clinical epidemiology. Really, as we went into this, reminding myself of how did this all start as an opportunity. I'm always hesitant to bring this up because when you go back and read, a lot of this is based upon Yale. And I know there's a lot of Harvard-Yale rivalry here, but let's just say some of the leaders in this field definitely came from our sister institution down the coast.
We can handle that, I think.
Yeah, I think we're just going to have to deal with it. And so, one of the ideas really back to the beginning of last century, really this idea that clinical epidemiology actually coming in an address to the American Society of Clinical Investigation from John Paul, a professor at Yale, was really the idea that clinicians for the first time were starting to think about the causes of disease, how they could position their work within the broader causes of what was happening to their patient. I think you can see the quotation. It's his aim to, of course, back then physicians were all men. So you can't really start to worry about this until like the last 2 decades, where it's interesting that the gender pronouns are starting to change. But if you go back to the history, physicians are always he's, I will say, in these papers. But so it is his aim to thus place his patient in the pattern in which he belongs, rather than to regard him as a lone sick man who has suddenly popped out of a healthy setting. And I will say, if I could just share where we were at the time where we started to see COVID-19, that was our aim. We were trying to understand what was going to help us understand the patterns that were driving what we were seeing on the clinical side. I think, for many people would trace the founding of clinical epidemiology to another Yaley, to Alvin Feinstein, who really led, I think, the definition of this field. And I'm just sharing one of the examples of his work, but really in a series of papers in the Annals, now back, I think, in the 60s, that really made the point, if we look at this diagram, that actually it was about the idea that we as clinicians were intervening in ways on the populations that we were seeing that allowed us to extricate information about the clinical course and what worked to change that clinical course, both for healthy hosts and for disease hosts. And he wrote, a quotation that I use fairly often, which is that each active treatment is an experiment performed upon a human host designed to change the course of a disease instigated in that host during a previous experiment begun by nature. And so I think it was this model of clinical epidemiology that I grew up in, this idea that we were bringing together clinical folks with epidemiologists so that we could integrate research and clinical care so that clinical decisions were driven by statistical reasoning and the ability to make sense of the data around us, and that research was driven by clinical knowledge. And obviously so much has been written about this. And so this is a vast oversimplification, but I'm going to use it for my purposes. I think one of the tensions that I've experienced certainly over the, it's a little hard to remember, 25 years that I've been in this, and many people have been doing it for much longer. I guess actually maybe I'm up to almost 30 years. Is that model has changed, and changed from really the concept of a clinician and epidemiologist working together. And it's introduced what I sometimes call management. Other people have called it the industrial side, the corporate side, where instead of this kind of almost seamless interface between clinicians and epidemiologists, what happens now is that epidemiologists do the research. They identify, let's say, the information or the evidence that can guide clinical decisions. And in my world, that is mostly then translated to what I'm going to call management. And that management might be an electronic medical record, it might be a guideline, but there's another group in here that actually then tells the clinician what they have to do. And my perspective, which I recognize is really very biased here, is that there's been a huge loss by the lack of direct connection between the epidemiologic way of thinking, epidemiology, and the clinical side being much more integrated. I think there's been a loss for clinicians. I think as people have written about this, that the benefit of using epidemiology to make better decisions, to understand statistical reasoning, to think about probabilistic information, still hasn't really made its way into medical training. We have an enormous amount of focus, as I think people have written, on the biology of the molecule in medical training, as opposed to the macrobiology of the human. And I think that makes us less effective as doctors, as clinicians, in terms of the type of care and decision making. And I think many people have written about the challenges on the other direction of having research that is less and less connected to the major questions facing medicine, as well, I would say, as potentially the challenges in defining disease and other things. So I am an advocate, to be clear, for this connection between clinical work and epidemiology. And so what I want to do now is just take us back a little bit and talk about 5 areas that I often think as major domains in this, and how they were different at the time of COVID-19. Whereas if you imagine, we in the clinical side really had no data to guide anything. And so what did that mean about how we bridged that gap, how we created those connections as we went forward? I'm just going to tell you the story from the perspective of the Department of Medicine at Mass General. There are many of these stories that can be written, many perspectives on this. So I'm just going to share one perspective from being pretty much on the front lines of what I think Tony Fauci aptly called navigating the uncharted. And I want to talk a little bit about a story. I'm going to give you a story or two for each of these areas: assessment of risk and prognosis, how we use diagnostic classifications or thought about diagnosis, evaluation of interventions, some things really around guideline development and what happened and how different it was, and then a little bit about the differences in dissemination of information that happened. So I'll just take everybody back. So this is a slide from one of the first briefings that I had when we first discovered that COVID-19 was in Boston. And so this was in March 15th. I mean, we're coming up on that now. Obviously, we knew this was happening before that, but we didn't have our act together here at the General to pull together these types of briefings until really the very beginning of March. And so this was obviously a picture that came from the Hopkins site. But what I want to share with you is at that point, March 15th, we had 4 confirmed cases of COVID-19 in the hospital. So you don't have to worry about exactly where they were, but we had 4 confirmed cases. We had 6 what they call persons under investigation in the hospital. So a total of 10 individuals. So what happens when you have 10 individuals with a disease in the hospital that you have no idea what to do about? You don't know the risk, you don't know the prognosis, you have no ability to make informed probabilistic decisions. So a number of things happened very quickly that I think made a big difference in linking that ability to make sense of the data to our clinical care. So the first thing that happened was that we were actually able to create cohorts of everybody in the hospital who met different diagnostic decisions. This is a recent list that I pulled, but we started this basically the first week of March. And so what you can see is that we actually pulled, I'm just going to show you the COVID ones here. We pulled together all the data for patients who met criteria. And then the clinicians themselves, most of them were house staff at that time, essentially tried to do their own cohort studies in the back of the envelope of looking through the patients who were in the hospital. When they admitted a patient, trying to identify patients who were like theirs and understanding based upon really various, people would call it low rent epidemiology, what might happen to the patients when they, if they had a patient who was admitted to their service. As you can imagine, the biggest question for them when they admitted a patient for COVID-19 was, how likely is this patient to need intubation? How likely is it when I admit a patient, do they need to go to the MICU? And so very quickly, they established these cohorts and essentially just basic 2x2 tables of the probability that a patient would be intubated within the first 24 hours of admission. And it changed our practice immediately, because what we discovered was that very quickly after admission, a high rate, about 30% of people were needing to be intubated. And so if you imagine, that is not true. And I do appreciate that, I'm not showing you the other data, but that is not true for most respiratory infections. Let's be clear. When people come in the hospital, a very small proportion of them get intubated. And if they do, it's a prolonged course. So this, what I would call the most low rent epidemiology of just creating rapid cohorts of patients, then led to the ability to create hypotheses about what might be going on. So people were using this not to create a p-value, not to really publish, obviously, or think about research in the traditional way, but to really learn very quickly from patients coming in and assembling them into cohorts in that way. So I could keep going on the number of hypotheses that were created, but as Bert told you earlier, one of my primary interests has always been disparities in care. So I want to tell you that story for just a second. So very quickly, as those cohorts were created of cases, one of the hypotheses that came out was that there was a much higher rate of Hispanic ethnicity and a higher rate of being of living in some of our more low income communities, Chelsea in particular, than there was a much higher rate of both of those things than we expected to see based upon normal admissions. So that then led to a really rapid assessment using publicly available data and other types of data, both in our system. So as this is going on, people are realizing the power of pulling these data together, creating much more rapidly accessible EMR-based data cohorts. But even this takes a while, right? So even as that's happening, it turns out what they did was they actually pulled the public data now. These are epidemiologic data, right? This is not clinical at this point. They pulled the public data. And this really happened on April 5th, as you can see. So this is kind of 2 weeks later. And what they discovered was that the rate of infection in Chelsea, can you guys see that? That's Chelsea up here, was enormously higher. At that time, New York was the known hotspot. You guys may put yourself back in that time. There was a lot of concern about rates in New York. So they pulled data and decided, and when they say they, these are my house staff. So these are residents on the front lines, people who traditionally, and I imagine I can say this as with some sense of humor in this audience, but these are the people who refuse to go to their epidemiology classes in medical school. Okay, these are the people who never showed up. I know them because I taught those classes. And so now they are on the front lines pulling epidemiologic data for the cases to try to make decisions about what to do. And so what they discovered was that we had an enormously increased rate of infection in certain communities across Boston. And what that led to was actually more traditional kind of clinical epidemiologic studies of defining populations, of pulling the data and assessing the contribution of different risk factors to the rate of infection. I'm just showing you one of such analyses here. This is an analysis of household transmission. And so what they were asking at that time was there a difference by race in household transmission? And what we did to help them do this was actually pull the data from our system for everybody who was infected. And then we matched it to the people in our system at that same household. Obviously, lots of potential for misclassification, lots of hand matching on apartment numbers, but it gave us, I think, a big picture sense of who was getting infected. If an index case in the household was infected, what happened within that household? And so the next part of that was that they discovered that actually in our system, that there were much higher rates of infection for Latinx individuals in particular, even after we adjusted for a bunch of comorbidities. So the question at that time was, is it all comorbidities, or is there a difference in the risk of transmission? And so what these data showed us was that even after we adjusted for a bunch of comorbidities in our population, that actually we still had a large disparity in household transmission. And so what it appeared at that time, and this was enough evidence for us to move to a process by which we rapidly intervened on household transmission in those communities. And these are the same residents I'm showing you in these pictures who skipped all their epidemiology classes, right? Like, I'm not sure they could even spell the words epidemiology. But they went from thinking that it was not relevant to using those data, using the ability to understand the contribution of a particular risk factor to developing these kits. So do you guys see these boxes that essentially were given to everybody who got infected in Chelsea to prevent household transmission in Chelsea, based upon them asking a clinically driven question and using epidemiologic methods. And, I'm not here to argue whether that was the right thing or not to do. What I'm here to say is, like, it was magical to watch it, to watch young people bridge the concepts of how epidemiology, how research could be used to make an immediate impact upon what we were doing, and really to see that spark grow in them. So I will say, obviously, and I don't have to tell this group this, the other stories that were equally kind of exciting to watch was that we weren't just looking inward. And I'm not going to spend a lot of time on this because I'm sure you guys have been a major force in this. But I found that my leaders were now reaching out across the globe to understand in a very Bayesian way. I mean, let me say, most clinicians do not live in Bayes, right? But these guys were reaching out to understand what was going on elsewhere and how they could bring that to their own clinical decision-making here. Here's one episode, lots of connections to Italy and China, as I think you all know, huge amounts of efforts that we were now creating knowledge across different platforms in a whole different way. Obviously, there were also many online tools that were rapidly stood up to try to understand, how do we create better cohorts? How do we leverage this energy with clinicians to create risk information, risk and prognosis information that we can use clinically? This is just an example of the COVID dermatology registry, but we had so many people stand up and decide they wanted to do this to help them make better decisions and to be able to improve our understanding. Okay, so I want to say, so it really was, for my first time that I've been in this, a time where the impact of what we could do from epidemiology in the clinical setting was really so apparent to everybody involved. So I want to talk about diagnostic classification just for a second, because here was another example of how this happened. And so I'm just going to talk about 3 different pieces of this, although they're really the same. So the first was that when this started, we recognized very, very quickly this classic epidemiologic problem that defining disease is actually really complicated. And I don't think that is usually appreciated on the clinical side at all. I think this is a gap that we often have when we're trying to bridge these worlds. And so the idea that we needed to recognize that if symptoms, infection, and disease were different here, and that was going to have huge implications for our guidelines, for research, for everything. The second piece was there's a lot of interest, and I won't dwell on this, on the integration of diagnostic test development and clinical care. So if we recognize that diagnosis is a probabilistic enterprise, then all of a sudden we're coming together to actually improve that process in a very dynamic way. And so I'll just show a little bit of that. So this is what we call, or what I call, the dynamic diagnostic journey. And I'm not going to necessarily kind of walk through all of this, but I guess there's a couple of things I just want to be clear, is that in early March or heading into April, this time that I was sharing with you already, what we were learning on the front lines was that we had no idea who had COVID, like no idea. And so I think what that meant was that we had to bring together the people who were developing, and this is in the blue, the different types of tests. So these are different machines doing the SARS-CoV-2 PCR tests. We had to bring them together with our testing protocols, right? Because it all depends upon who you test. And I don't think anybody had ever really fully gripped that on our side, right? Is that if we didn't have testing protocols and we didn't understand the selection effects of who was getting tested, then we were really making inaccurate decisions about who had disease and what the burden and rate and other types of prognostic information we needed. And then I think, the really interesting part for me are the green boxes, where actually there was an immediate move to understand how do we use prediction modeling, how do we use more advanced ways of diagnostic classification at the time when we were moving through this journey. And so I've honestly never seen, I've been fighting for this in breast cancer for 30 years. That honestly, the diagnosis is a more complicated thing than we understand. Certainly, if I look at mammography screening, if you just think about how complicated this is, and all of a sudden we had a disease where we were all aligned saying it is about who we test, it is about what tests we use, and it is about how we combine that information with other pieces going on. So I'll just, actually, I think maybe in the interest of time, I'll skip this, but this was a study that was done. We did looking at healthcare worker serologies as part of just an example of this. We were trying to figure out whether or not we had a serological test that worked at the same time that we were trying to figure out whether or not our PPE, whether or not our personal protective equipment was preventing infection. And so I don't want to go through the specifics of this, except for to just highlight the integration of those two things. And what we ended up with really was a lot of iterative data looking at different platforms. Here's an Abbott platform, a Biomedomics, which is a lateral flow assay platform, and really understanding like where is it that we think we have overlap and we can make a decision that this person had COVID-19. Where was it that we didn't necessarily have overlap and we were concerned about false positives, and using this information rapidly to improve our case classification, our infection control procedures, and to validate the tests as we move forward. It was an incredible set of collaborations that were going on at that time. So this gets back to this other part of it of given that the tests are imperfect, that disease, symptoms, diagnosis are all very complicated, we've got to then understand that we're going to be using information probabilistically to make that diagnosis. And so initially that calculator was a human brain. So they set up a BioThreats review committee, the BioThreats infection status review team, that actually stayed up all night. It was crazy. I still feel like we could have done better. But these people would get sent a case that had one positive test or some of the risk. So whether they were COVID risk, COVID presumed, a COVID infection. So they would get sent the case. As you guys can probably see, this is an order set, just so you know, a consult. And then their brain would be used to review the chart and decide whether or not the patient truly met some threshold for COVID. Not the most efficient way to do this. That then led to this thing that we now use, which is called the CARL, or a COVID risk calculator, that basically took that information and then created a classification schema, using subsequent testing as eventually the gold standard here, to be clear. So where somebody ended up weeks later became our gold standard for this particular one. And now that classification scheme was put into place. So this paper was published in February, but and I'm not going to go backward, but if you go back, or maybe I'll go back really quickly. So if you look at this, so we were in this chaos in March and April, and they created a prediction model. They tested it and implemented it by May 20th. So we moved from, I can't do the calculation, but it was pretty fast if you think about it. And it dramatically changed the experience on the clinical side, so that I'll just pick on this one, which is essentially, how much time was the ID service spending on this? And you can see pre-CARL and post-CARL, and it just dropped dramatically. So everybody was using this tool. These are how long patients waited in this limbo state. Limbo is never a good state for patients, just to be clear. And so this is a paper that they've now published that kind of showed essentially these different issues. So I'm looking at the wrong screen when I say this, but you guys can see this is the ID physician time. This is the amount of time the patient was in what we call under investigation. And this was essentially the testing strategy, with the black being the major effect on our test utilization over the time, because tests at that time, we forget about it. But at that time, tests were rationed. We did not have enough tests. So we had to figure out how to use them most effectively, not keep testing people where it wasn't giving us more information. Okay, so let me give you the third example in this storyline. So the third example, I think it really comes from how we started to evaluate interventions. And so, you know, I often remember this from like, and I'll get back to this, from the political morass of what happened in my life at that point, because half of the members of the board decided that we needed to prove that hydroxychloroquine cured this disease. And so I got just call after call after call, and we can come back to that at the end. But I think what it really brought up was that there was an enormous interest in people identifying potential interventions that might work. And those came from biological evidence, from biological plausibility, what we started to learn about the ACE receptor, about all sorts of other different things. I'm not going to go down the whole biology here. They also came from experience with other either coronaviruses or other areas with ARDS. You know, we brought all of our experience, we brought the biology. And I think the list of potential things we needed to study was enormous. And so if you think about that, like the desire to move that quickly to study things meant that we had to come up with a new way to prioritize how we were going to do trials. I'll just give you one quick example that was a big part of my life in the first several months, was the questions around IL-6. So an enormous amount of interest in IL-6 for reasons that, you know, make sense. There was lots of evidence that IL-6 leads to the increase in these laboratory markers. We were seeing increases in all these markers and from all of our patients. Obviously, it also leads to these other manifestations that we were seeing in patients with COVID-19. And because of, I mean, obviously so much desire to have an effective therapeutic, you know, that led very quickly to this idea that we were going to do just with the current IL-6 blockers. And this is just one snapshot. An enormous number of trials needed to be done now, right? I mean, it wasn't like they could be done in 2 years. Like, we needed to do them now. And I think one thing to remember is we needed to do them now because we knew we were in a surge, right? We knew that when the public health measures came in, that we would see a decrease in cases. So we had to get our act together. And so one of the things that we did and many other places was try to figure out how to fix the chaos that usually occurs in trial enrollment. So this was probably late March, again, I'm showing you. And we had all these different trials, even with us. Now at that point, you know, you guys can see at that point, like we had in this red star, probably about 30 or 40 inpatients, but we knew we were going to be going up, right? So we knew we had a moment in time that either we were going to be able to make studies work, or we were going to have a bunch of investigator teams running around fighting about whose patient got on what study, which is a very classic way that this can happen. So what we ended up doing was 3 things. So the first is we stood up like really instantly a scientific review body that prioritized the scientific impact of those studies. And we took that from the Cancer Center. Keith Flaherty led that for us. So we decided which studies were we going to prioritize. But that wasn't the answer, right? Because even then we would have 10 or 12 enrolling studies. And what we discovered is that whether or not the patient got offered that study was really just dependent upon kind of the investigator's like childcare situation. So if the investigator had a lot of childcare, they could come in, they could enroll a lot of patients. It was a hard thing when we were moving that quickly. I'm obviously making a joke about the childcare, but it wasn't necessarily driven in any rational allocation way. So we set up this thing called the MGH COVID Studies Implementation Core. There's actually been a paper in the New England Journal about this since then. And what we did is that we had the leadership here identified every admission who might qualify for a study at 6:30 in the morning, starting at April 9th. They then reviewed all our open studies, figured out whether the patients met the inclusion or exclusion criteria for each enrolling trial. And if the patient met the criteria for one study, they sent that patient's information to the team, and that patient was hopefully enrolled in that study. If they met the criteria for more than one study, we made a decision at that time that they would randomly allocate those patients across the different studies for who approached the patient first. And then if the patient was not interested in that study, the next study would approach the patient to give information. Patients were given information about the range of trials available so that they could know that they could participate in this study if they didn't want to do that study. And so what they showed is that we were able, over that period of time, we screened over 1,600 patients, you guys can see in this phase. We referred over 1,000, almost 1,000 of them met criteria for a trial. And you can see like the number of studies that were done here. And I'm not going to show you all the papers that were published, but an enormously more efficient approach to getting studies done and enrolled in this time period over the way. And I think several things. We led the dual antibody study that just came out in Mike Dugan, one of the faculty who led this effort with Hannah Sachs and Crystal North, led the dual antibody trial that just came out that showed really dramatic improvements in hospitalization rates in the ambulatory setting. I'm sure you guys have seen those data, but it changed completely the platform of how we were doing trials. Okay. I just wanted to make two more quick points, and then I'm really looking forward to the discussion. So I think I would say the fourth component was just how quickly guideline development changed and how dynamic and clinician driven that guideline process was for us. And I think there were really three pieces of that I'm just going to highlight that for us were central to this. So this effort that happened almost overnight to curate literature in the area and bring it together in ways, the concept of when you don't have evidence, how can you use biology? How can you use experience to create narrative reviews that can then lead a conversation? And then how we developed our own rapid consensus-driven guideline process that incorporated both of these to try to help clinicians make better decisions. So I'm sure you guys have all seen this. I don't have to pick on this one in particular, but I think resources like this became the Bible for us very early on. Being able to keep up rapidly with the information that was coming out was absolutely critical for the people who were involved in the reviews that I'm talking about, as well as I think for many clinicians and researchers. One of the efforts that started for us was something that they called the FAST Literature Assessment and Review. I can never figure out why they call it FLAIR, but we called it FLAIR. And so what it was, and you can see this, was led by a guy named Corey Harden here, who's one of our pulmonary docs. And I think what they did is that they realized that they could take advantage of a diverse group of clinicians and researchers across the MGH to pull together expertise to address top of the mind, I will say, clinical questions that were actually coming up from the MICU, coming up from the floors, but do it in a way that included a lot of the basic scientists who were here, as well as the review of what was published literature in the area. And so I don't have to like call out the people on us. They'd probably be embarrassed if they knew I was showing you this. I think they enjoyed their different backgrounds at the time. But they then have published this, and this effort was unbelievably helpful for us because we could, from the front lines, have somebody submit a question to it. Questions about how to manage ARDS, questions about how to think about heart disease, whatever the clinical issue was. And then they would produce something within 3 days that would help guide that discussion. It's now used all over the globe. It's been an incredibly powerful tool. That effort then led, or at the same time as that effort was being developed, we also developed something that's called CHANT. And again, I don't think MGH is very good at acronyms because I honestly can't remember what CHANT stands for here. But let's just say it was our clinical guidance that was developed by a huge multidisciplinary team, 70 individuals daily on a call for an hour with somebody presenting the latest evidence and then thinking about what would happen to make a decision about what we needed to do for patients. And these were like big decisions, to be clear. These were decisions about therapeutic decisions. These were prognostic decisions. These were not minor decisions that we were facing for clinical care. I don't have to go through the whole team, but it was a fairly large team that included every discipline that we thought was relevant at the time. We ended up having to bring together a large immunomodulatory group because it turns out that most of the controversy was about the role of immunomodulation in managing these patients early on. And we had to create an entirely separate consensus-based group in that area. And that group was directly linked to the trial prioritization effort. So let's say that group said, we are at equipoise about an IL-6 inhibitor. We don't know whether we can recommend it. That would then go back to the trial prioritization group, and they would know that out of all of the requests they were getting to actually start a trial, that we should prioritize the IL-6 inhibitor trial versus a trial of nitric oxide or something else. And so it was a direct feedback loop, if that ends up making sense, to what is the most important knowledge that we're missing when we're creating a clinical guideline. Obviously, oh, here it is. It was called the COVID-19 Here and Now Treatment. I don't know, like that doesn't, anyway, let's just say that's what CHANT stands for. So those guidelines, the clinical management conferences were held 7 days a week and then translated into updated guidelines within 24 hours. Obviously, I already made the point that we're internationally informed also. So they would have clinical conferences weekly, sometimes 2 or 3 times a week to understand what people were seeing in other countries. And then obviously those things were then translated. This is our CHANT picture here, but to IDSA and other NIH guidelines. But we needed the dynamic nature. I mean, that evidence base, as you guys know, is changing so quickly that it was critical for us that we had this feedback loop in how we were doing it. So then I just want to finish by saying the other piece that was really different than anything I've ever experienced was the dissemination of information. And so, you know, I still think we don't understand. I think this has changed everything. And I honestly don't understand how this is going to work moving forward. So I'll just share some of my, what we experienced, but I'm sure you all are thinking about this a lot. So I will say the first thing that happened on our side was that we realized that we weren't the only people coming together and making these guidelines, right? So, they were being made at the Brigham, they were being made at UCSF, places that were early in the surge, were feeling the patient, were experiencing the surge first, were way faster at creating these systems than places that were later. And so we had, I thought, really a duty to figure out how to disseminate that information. And so I would say we're still struggling with what that means and how to do it. One thing we did was try to decide, well, it's going to create chaos out there if what the Mass General says to do is different than what the Brigham says to do, is different than what the UCSF says to do, if that makes sense. So we tried to find what we would consider an honest broker who could bring together all of our guidance documents and create a summary for that. And we used the AAMC at that time, who actually has a ton of students, as you guys might remember, medical students about that time really were all of a sudden completely disrupted. They were told they couldn't come to the hospitals. They were really looking for things to do. And so we created a process that pulled together documents from across many different medical centers, and actually put together this like clinical alignment summaries and shared those. I will say, interesting, this may be something about the American mind or how we think, is that, you know, people still tended to respond to the single institution guidance more easily than this. And I think I've thought a lot about that. But anyway, so that was one thing that happened. I would say the other thing that happened is that, you know, people went to what I used to call the gray literature, right? So all of a sudden, everything I saw was coming from people going to, I think, incredibly effective, very well resourced, very effective analytic sites that were doing all sorts of rapid epidemiology, rapid clinical epidemiology, and posting those essentially, whether in 538 or through Hopkins or the COVID tracking project or all of these different areas. And so people were using this information. And then, of course, I don't think I have a slide about it, but I think the challenge of then seeing if all this information is out these other ways, what is the role of the preprint uptake, right? I'm sure you all experienced. I was at a conference for JAMA, where I sit on the editorial board, probably right before the pandemic came out, where there was this enormous debate about the role of preprint servers and what should happen, and just the complete uptake of the preprint process during COVID-19. And then the challenges of recognizing of the false positive rates that happen in that, and the major mistakes that can be made through that, I think have created an enormous amount of uncertainty in this area about how do we disseminate information in, you know, the current era. So I just wanted to say that this was an incredible experience to be on the front lines for. You know, obviously I could tell lots of other stories, but I think if I think about what it taught me about what clinical epidemiology could do, I wouldn't have missed a minute of it. And I think it was across all of these domains. I want to just show you really quickly one of the things that it drove us to do, and then I'm going to stop. We have now set up a clinical informatics consult service led by Tom McCoy that actually is allowing those same house staff to be able to answer clinical questions, where we can get in a clinical question, and we're trying to refine that process to do real-time epidemiology for the patients that they see. So in the interest of time, I'm not going to spend a lot of time on this, but basically I'll just show you, I'll skip this method thing, maybe show you a couple of examples. So one example was one of the house staff was interested in, had a patient with something called malignant otitis externa, and wanted to understand whether or not that patient was at severe risk of diabetes, and what was the relationship. I don't want to go through these examples in the interest of time, but I think what it led to was a rapid interest amongst the house staff in figuring out how to use our data to be able to make better decisions for patients. Here is a decision about diabetes screening in a patient with an ear problem, and how to classify our data, how to use our data to bring clinical work and epidemiology together in real time. This is another one that is actually about an age-old debate we have of whether or not a patient could have TB if they have a low sedimentation rate. And so the house staff have been taught for years that if they don't have a high ESR, they can't have TB. They decided to go back and use what I will call these low-rent epidemiology methods to look at that question and to figure that out. And so this is a beta test. I don't want to make it sound like I'm advocating for these methods. I'm not trying to say that this answers the question. I'm not here to talk about selection bias or confounding or any of those things. I'm just giving it to you as an example of how excited people became about the ability to learn from our patients and to do that in a way that wasn't about a single patient, but was about that model of epidemiology and how we think about epidemiology. I'll just say finally, and this is my last slide, that obviously there's a lot of challenges that we experience. So disease definition remains complicated. And I would say on the clinical side, that is often underappreciated. We just talked about the publication dissemination system that I think right now is stressed and really unstable. I think we learned there's substantial, we all know this, but huge amounts of variations in research capabilities across the country. So after we set up our clinical trials infrastructure, obviously the surge started to go down in Boston, and we were eager to support communities in Texas and in Alabama and in other areas that were experiencing the surge to start their trials. They just didn't have the ability to do that. They didn't have the infrastructure, the people to do that. I think we've had this constant need to beat back dogma. Everybody wanted to say, yes, everybody should get an IL-6 inhibitor. How do we fix that desire for certainty? We're fighting a lot of issues around privacy concerns and how that will hold back our ability to bring these questions to the bedside. And then I think, as we all experienced, the political interference that existed during this was really challenging for us in many, many ways. So I'm going to stop with that and stop showing my slides. And Bert, I apologize for going a little bit late. I'd love to get any feedback people have in the last 5 or 8 minutes here.